Hello, everyone, and welcome. Today, we will be investigating the ethical issues of providing venous thromboembolism, also known as VTE, prophylaxis treatments for inpatient hospitalizations. You will also be hearing from multiple speakers today, including Madeline Beiser, Josh Joseph, Neil Kaisman, and myself, Heather Trin.
Hi everyone, this is Josh, and I will be discussing the risk factors and the last two slides of this presentation. Before jumping into this dilemma, we first have to understand the predisposing factors that increase one's risk. So there are three different groups: high, moderate, and low risk. Low risk patients are young patients with no risk factors for VTE. Moderate risk patients have at least one risk factor, and high-risk patients have multiple risk factors. So risk factors vary from either being elderly, which is older than 70 years old, or either having a pre-existing medical condition such as diabetes, immobile patients, either having a history of a VTE or PE, critically ill patients admitted to the ICU, someone who has suffered a stroke with lower extremity paralysis, advanced congestive heart failure. This is because the heart is damaged and weakened, causing decreased cardiac output and blood stasis. Then there's active cancer, acute respiratory failure, thrombophilia, which is the abnormality in clotting factors, which increases your risk, recent surgery or trauma. So with this, it's very important to get your post-operative patients up and ambulating. And then there's obesity, and lastly, ongoing hormonal therapy such as estrogen.
Now that Josh has gone over the risk factors associated with developing venous thromboembolisms, I'm going to go over the prophylaxis guidelines. Now, there's a few different types of prophylaxis. You have pharmacological prophylaxis and mechanical prophylaxis. This slide is set to go over the mechanical guidelines of prophylaxis. So mechanical prophylaxis is indicated in patients who are high risk, and it's recommended in patients who are moderate risk. However, these are both in conjunction with pharmacologic management, which we're going to see on the following slide. Um, for for me as a nurse, I think for moderate risk patients who seem non-compliant, I would use mechanical prophylaxis as a bargaining chip if they're not interested in maybe cooperating with blood thinner shots like heparin or Lovenox. I would say, maybe how about I give you the heparin, but you don't have to put on your sequential compression stockings, something like that. So the few different types of mechanical prophylaxis are sequential compression stockings, TEDs. You could do any type of active or passive range of motion, which is walking around is helpful. Doing plantar flexion while you're laying in the bed is helpful. Anything that's really going to increase the venous return of blood to the heart. Some of the benefits for mechanical prophylaxis over pharmacologic, if you're just going to go with one over the other, is you don't have any risk of complications with mechanical prophylaxis like you might with pharmacological. A lot of the pharmacological agents will put you at risk for things like bleeding. So moving on now to the pharmacologic guidelines for prophylaxis of venous thromboembolisms. It's indicated in patients who meet either the medium risk or the high risk categories. And common drugs that we see are Lovenox and heparin. It's interesting, Lovenox has the smallest incidence of DVT formation while you're currently taking the medication. And another benefit of Lovenox is that you only need to give the shot once a day. So Lovenox remains the gold standard essentially in VTE pharmacologic prophylaxis. That's what you're most commonly going to see. The next most common you're going to find is heparin. Heparin injections need to be done about usually Q8 hours, so 3 times a day, which a lot of patients really don't enjoy that, and who blames them? Heparin can be used when the patients have a low GFR. GFR is something that indicates kidney function, and low GFRs are going to be anything less than 60. So if you have a GFR less than 60, it's likely they're going to give you heparin rather than Lovenox, and then you're going to be in for the 2 or 3 shots a day. So we don't want to use some of the pharmacologic prophylactic agents on just anybody. There are contraindications, and the big risk with these blood thinners is they put you at risk for bleeding, as we all know. So some of the contraindications are going to be active bleeding, or if you're a high-risk patient for bleeding. So anything from an ulcerative disease to recent GI bleeds or recent surgeries, those are going to rule you out. If you have a planned surgical procedure coming up in the next 6 to 12 hours, but I've also seen it as far as 24 hours, it really depends on what blood thinners that you're taking. They're going to hold those meds. Thrombocytopenia, which is going to be a low platelet count, is obviously going to contraindicate you from receiving those. And then anybody with bleeding disorders, that's going to be like your hemophilia patients. They're not going to be getting those blood thinners. And mechanical prophylaxis, I mean, the issues you could run into are skin integrity. It's if you have something constantly compressing on your skin, if you get a little bit moisture down there, it's easy for the skin to break down, especially if you don't have the best nutrition, which is something we see a lot in our older patients. They have poor nutrition, they have weaker skin, they're overall just not in the best of health, their immune systems are compromised, and on top of that, you're adding this constant pressure on their feet, that's going to be a recipe for skin breakdown. So they do have their benefits and their drawbacks. However, I will say, as long as it's not completely contraindicated, the risks of a pulmonary embolism is going to be much higher than something like skin breakdown. We really have to weigh the risks versus the benefits in these types of patients.
Now that we have gathered some background information about VTE prevention and treatment, here is the dilemma. The most concerning predicament found is that patients are refusing VTE prophylaxis treatments. The Centers for Disease Control and Prevention, also known as the CDC, states that VTE is the leading cause of preventable hospital deaths. So with that in mind, we as soon-to-be nurses have to think of why they might be declining treatments. Is it an educational issue where patients do not fully understand the reasoning and may see the shot as unnecessary? And/or, at what point should VTE pharmacologic prophylaxis, such as Lovenox, be considered for inpatient hospitalization? For instance, if they are fully independent and meet all of the required VTE mechanical prophylaxis, like using compression every night and walking once an hour, do we really need to administer Lovenox? The issue of refusal has many different reasons, and once one is identified, more will become present. It causes a domino effect of concerns that need to be addressed. As nurses, when a patient refuses a treatment, we must always assess why without saying it as it can pass judgment. For example, asking the client, "Can you tell me more about your concerns about receiving these?" Or, "Is there any questions you have that I may be able to answer for you?" Or even assessing if they know what they are getting and why they are getting it. Education is a massive part of nursing, and if not done properly or at all, patients are more at risk for health issues to reoccur or new ones to arise. If a nurse comes in to a patient's room and says, "Hello, I have a shot to give you," most people would become uncomfortable as they would not enjoy receiving a shot. And once the nurse says the name of the drug, some people may become even more in disarray, as to them, a name of a drug means nothing. To them, it is just some weird random name they may have never even heard of. The average American person does not have the education that nurses do, So it is our job to be able to help them understand preventions, treatments, and the reasonings behind it, as it can improve their health. But of course, we must not force them into thinking that if they refuse, their health will decline. Of course, there is also special considerations to that. We'd have to explain to them their risk factors and how if they do recline, it will put them at a higher risk for issues to develop. Also assess if they understand what a VTE is and explain how it can cause issues without scaring them even more. There's also that fear of pain coming from receiving a shot. Clients may have a lack of perceived need for the drug, and they might think that it may harm them instead of benefit them. Maybe explaining to them where they're getting the shot and showing them maybe how small it is would benefit to making them feel more comfortable. As these reasons focus on more pharmacological treatments, we must also remember that there are mechanical interventions that can be done, such as compression stocking or compression boots, and also just getting up and walking, moving around, active range of motion, passive range of motion. In the American Association of Critical Care Nurses practice alert article, the authors found the reason for clients' refusal of the compression boots were because of the disruption of sleep due to the noise and the discomfort, and also the improper usage by staff of the compression boots. So they may not be applied on right, they may be too tight, anything like that that can make the patient uncomfortable. When a client starts refusing, who becomes responsible for educating the client? Also, what if the patient desperately needs the VTE treatment? Is the education solely a nurse's responsibility? And on the other hand, how far should a nurse go to educate high-risk patients of the importance of the prophylaxis, knowing the time constraints? And since nurses are short on time, are they quick to accept patient refusal? What about their resources? Do they have enough required to supplement their explanation? What is considered best practice for nurses in managing VTE prophylaxis refusals? These are all great questions, and as nurses perform many tasks, they are not alone. Discussion with healthcare providers and other team members associated with the care of the client are important. There are also ethics committees to contribute to the determination of giving treatments even if the patient does not want it but needs it. Education and care of a patient is a team-required job. Everyone has a role to play, and they are all different. Nurses also have access to many resources for education. Hospitals have patient education folders to give out, but the issue is the nurse being short on time and not being able to properly educate the client.
This graph you see here is a graph that I actually pulled from the floor that I work on as a tech. What this graph is showing you is we have a rule at my institution that you really should be hitting that 90% of your patients should be receiving the DVT prophylaxis, the pharmacological prophylaxis, so their heparin or their Lovenox. They want a 90% delivery rate. Because you always have your patients who aren't going to want it, and the patients always have the right to refuse. That's within their right. So this chart is specifically looking at heparin administration, and it's going through, I believe, the past 12 or 16 months, showing where we stood, and it's kind of all over the place. Some months you have 97% adherence, and sometimes it drops to about 85%. And what you realize is the months with the lowest adherence are the months that we are usually the busiest. It's a respiratory floor, a progressive care unit, and around those months we get a lot of pneumonia, influenza type patients who need BiPAPs or high flow nasal cannulas, things of that nature. So it kind of begs the question, maybe the nurses get too busy to really educate the patients and say, this really is something that's, in your best interest. Maybe it's just the patient says, I don't really want a shot today. And, when they're too busy to educate them, they just say, okay, So that's just a thought. That's not, concrete. It's just, it's a nice visual to see that it really does go all over the place.
Okay, here we have a chart showing the different types of VTE prophylactic medications ordered and the number not administered, and also the number not administered and documented as refused out of the numbers not administered. They also have the percentages there. It breaks it down by race, which can help nurses see where they need to focus some education on, as well as by gender and the type of hospital floor. That can show hospitals where they need to focus on educating their nurses on proper protocols. For opposing evidence, they have respect, patient request, and comfort. Patient hospital satisfaction survey ratings may go down if patient feels forced into getting a shot, and then in turn, the hospital can lose funding over low source scores. Risk of bleeding, especially in fall risk patients, using improper dosing, expensive and not always on hand antidotes if the patient quickly needs surgery and the medication has a longer half life. Lovenox versus heparin, whereas Lovenox has a longer half life than heparin. For the opposing evidence to the ethical dilemma of VTE prophylaxis, it really comes down to respecting what the patient wants. Some may feel that by a nurse educating them and encouraging them to comply with the prophylactic medications, that they are being forced. It is hard for patients to understand prophylactic medications, occasionally due to the fact that there is not yet an issue at hand that needs to be treated. It is just preventative. For supporting evidence, might want to try to explain to the patient in a way that they understand. Like aspirin is a very common prophylactic medication. It's easier to relate to. They can see commercials for it. Whereas if you're just telling them they need this medication, it's going to be harder for them to understand why in some cases because they don't actually have a problem. It's just preventing a problem that can come up. And then the use of VTE prophylaxis reduces the number of preventable deaths in the hospital. As many as 70% of cases of hospital acquired VTEs are preventable through prevention measures such as use of blood thinning medications called anticoagulants, which help prevent blood from clotting, or use of compression stockings, yet fewer than half of hospital patients receive these measures. It reduces the risk of fatal and non fatal complications. The solutions to the ethical dilemma could be proper patient education and further investigation of refusal, proper identification of patient risk group, proper use of interventions, proper discharge instructions, proper education of nursing staff. VTE prophylaxis can be implemented on a case-by-case basis. It's the team effort is needed between all team members for a positive and beneficial care of patients.
Nursing and healthcare. To address the dilemma, hospitals need to educate their staff on what the issues are and how to resolve them. Education can be in the form of annual compliances that need to be completed. Charge nurses and managers can discuss the issues with their staff, or classes can be offered for the staff to take. The education can include why it is important to identify who is at risk and why patients' refusals can be life-threatening. They need to include how to educate patients who refuse in a way that is not as aggressive, but trying to educate and help them in a therapeutic manner. Even though patients have the right to refuse treatments, there is still concern about why they are refusing it. As nurses, it is crucial to investigate patient non-adherence to therapy, along with providing proper education. Sometimes non-adherence is due to lack of understanding or fear. Not only must we explain positives, but also negatives, which enhance the emergence of a trusting relationship between the nurse and patient. Patients who are at higher risk for developing a VTE causes a high priority for nurses to assess their non-adherence along with providing education. This project shows the reality of how patient refusal to treatments vary from person to person, and each scenario needs to be approached differently towards the patient's concern. This impacts future practice as it is common for patients to refuse VTE prophylaxis, which has helped us prepare for what actions to implement when the issue arises.